For patients with non-valvular AF, the dominant therapeutic approach is systemic anticoagulation, but there is a huge gap between people who qualify for therapy based on their CHADS VASc score and those being treated. Plus, are the right patients being treated? Because quite frankly, as you've seen in some of these interviews, some low-risk patients where the recommendation says no need for oral anticoagulation, they're getting it, and some high-risk patients who really do qualify are not. So we're here to discuss NCDR data being reported here in Orlando at the AHA 2015 meeting, and I'm with Dr. Lucas Marzec, who is an MD, fellow cardiac electrophysiology at the University of Colorado School of Medicine in Aurora. So it's the introduction of novel oral anticoagulants, and it's exactly what's happening with the oral anticoagulation rates in AF, insights from the NCDR PINNACLE Registry. We could use some good news first, and I think that is one of the reasons I wanted you to talk to us. Why did you do the analysis first? Before we get into the data and what you did, why?
Well, as you mentioned, there's been a well-documented history of underutilization of oral anticoagulation for atrial fibrillation, but most of that data came in an era when warfarin was really the only option for anticoagulation. And we knew that with the introduction of the novel oral anticoagulants, that changed the game in terms of what was available to patients and practitioners for anticoagulation for atrial fibrillation. But it's really not clear if and how that has affected overall anticoagulation rates, and also if they're being used, the novel oral anticoagulants, in whom are they being used? And so we wanted to answer those questions by doing this analysis.
And so you went to the NCDR PINNACLE Registry, and exactly how many patients did you look at and what did you find?
Yeah, so we looked at almost 450,000 patients. The NCDR registry is an outpatient registry that looks at patients who were in cardiovascular care. And amongst almost 450,000 patients, comprising almost 1.5 million outpatient visits, we found that between 2008 and almost the end of 2014, there was a significant increase in the number of patients with atrial fibrillation and a CHADS VASc score greater than 2, that is people who have an indication by guidelines for anticoagulation. We found that there was an increase in the overall rates of anticoagulation during that period of time.
So what did it start at and what did it end at?
So we started at roughly 50%, so it was 51.1% and it increased to 61.2% by the end of the study period, which ended at 2014.
So we could still do better, but obviously the direction is correct.
Exactly right. We still have plenty of room for improvement, but it was encouraging to see that the introduction of the novel oral anticoagulants was associated with an increase in overall rates of anticoagulation.
And what can we do to keep that trend going? We've got to get those numbers up if we can, but what do we do?
Yeah, so one question which you alluded to earlier was whether or not we're anticoagulating the right patients. Are people who are at high risk receiving the medicines in the appropriate way, and how many people are at low risk receiving the medicines? We specifically looked at patients who are at high risk for stroke, only those who had a CHADS VASc score greater than 2. And the average CHADS VASc score in our cohort was 3.5. Wow. And so this is a high risk cohort. And while we were encouraged to see that overall rates of anticoagulation increased, it certainly is below what we would hope. I think further work needs to better understand why patients who are not receiving anticoagulation are not getting any therapy. We excluded patients from our analysis who had a clearly documented contraindication to anticoagulation. So it's important to understand that within the context of what we're able to do to understand who is not eligible for therapy. But I think we need to understand who was eligible for therapy, who didn't get therapy, and why practices choose to anticoagulate certain patients and not others. We certainly found patient factors associated with the use of anticoagulation, so we need to better understand what drives practitioners to identify those patient factors that are associated with use.
So what did you find specifically? Did you look at this?
In terms of the patient factors associated with use are in some ways encouraging. It's risk factors for atrial fibrillation and stroke that are known. So people who have had a prior stroke or TIA were at increased risk.
They are at the biggest risk.
They're at the biggest risk, and they were likely to receive oral anticoagulation, as were people who have hypertension, diabetes, who are also at risk for stroke related to atrial fibrillation. We did find that people who have coronary artery disease or peripheral arterial disease were less likely to receive oral anticoagulation. We don't know why that association exists, but that at least speaks to one potential population as to that may be.
They may just be considered too high a bleeding risk?
Certainly a bleeding risk can be a factor, so that patients either have an estimated bleeding risk due to medical comorbidities that may make practitioners less likely to use oral anticoagulation, or they may use other medicines like antiplatelet therapy that either practitioners believe protect patients from stroke related to atrial fibrillation or those antiplatelet medicines in conjunction with oral anticoagulation may give patients and practitioners pause in starting anticoagulation for fear of bleeding.
In theory, they should be using bare metal stents instead of drug-eluting stents for some of these patients who are high risk, but data being presented here is showing that that's not necessarily true. We're still seeing an awful lot of patients who probably should be getting bare metal stents, but they're indeed getting the higher risk drug-eluting stents, even though they have AF and they have this extra risk to begin with. It's a little frustrating.
Yeah, there's cause for frustration. I think that the role of antiplatelet therapy for secondary prevention of coronary heart disease and peripheral arterial disease is here to stay. I think the question is, how long do people need to be on dual antiplatelet therapy?
Yes.
And
that's a huge debate.
Exactly right, and I think that's continued to ongo, and there are differences of opinion. But from our standpoint, people who have coronary artery disease and peripheral arterial disease are not at reduced risk of stroke related to atrial fibrillation, and they're not being anticoagulated at the same rates as others are.
Well, I think the good news is that it is moving in the right direction. You know, if you've got 60 who are on it, you have to assume that there's not 40% where it's contraindicated, so there probably is room for improvement.
That's exactly right. While there are certainly patients in whom there's a clear contraindication, or there are patients in whom patient preference dictates they will not take anticoagulation, right, it's unlikely that that comprises 40% of all eligible patients. And so while our results are encouraging, we do still need to go a long way to improve the rates of anticoagulation for AFib.
Well, we have a variety of papers being presented that is NCDR data here at the 2015 meeting of the American Heart Association. Please check out CardioSource World News, CardioSource World News Interventions for all of that data. For CardioSource, I'm Rick McGuire.